All right, everyone, let's begin our journey into the functional anatomy of the knee. I want you to imagine that we are standing in the dissection room, and in front of us lies the most remarkable joint in the human body, the knee. Now, before we get lost in the details, remember this. The knee joint is the largest joint of the body. Think about how often you use it. Walking, running, squatting, even just standing upright. It is a joint that endures enormous loads and, at the same time, has to balance stability and mobility. This balancing act is made possible by a set of unique structures: menisci, cruciate ligaments, and a carefully arranged set of bony surfaces that, interestingly, are not naturally compatible. In other words, if we just had bone against bone here, the knee would be highly unstable. Nature had to design extra stabilizers: menisci to deepen the articular surfaces, ligaments to bind to bones, and muscles to provide dynamic support. At its core, the knee joint is formed between the femur and the tibia, but there is also the patella, the largest sesamoid bone in the body, embedded within the quadriceps tendon. Together, the femur, tibia, and patella form two major articulations, the tibiofemoral joint and the patellofemoral joint. Keep in mind that while the fibula sits nearby, it doesn't directly participate in the knee joint. It plays more of a supportive role for muscle attachment and lateral stability. Now, let's zoom in on the bones, beginning with the distal end of the femur. Picture the femur as a strong column running from the hip down to the knee. It is the longest and heaviest bone of the body, and at its distal end, it flares out to form two massive condyles, the lateral condyle and the medial condyle. There's an interesting geometry here. The anatomical axis of the femur, the line through the shaft, does not perfectly align with the mechanical axis, which runs from the center of the hip to the center of the knee. The femur comes in at a slight angle, about 9 degrees medially, and this creates a natural valgus alignment of the knee. In fact, there's about 3 degrees of angulation between the mechanical and the axial axis. This angulation is crucial because it distributes body weight more evenly across the joint. If this alignment is disturbed, whether by trauma or congenital variation, you might see conditions like genu valgum, knock knees, or genu varum, bow legs. Looking closely at the condyles, there's one special landmark I want you to remember: the lateral epicondyle. This bony bump on the outside of your knee is not only palpable in a living person, but also serves as an important attachment site for the lateral collateral ligament. So when examining a patient for ligament injuries, palpating this region gives you both orientation and diagnostic clues. To summarize this first section, the knee joint is a structural marvel. Bones shaped with subtle asymmetries, supported by ligaments and menisci, all designed to achieve a delicate balance of strength and motion. As we move forward, we will dissect this region layer by layer, just as you would peel back the structures in the lab, starting with bones, then ligaments, then muscles. First, pause a moment at the top image. Notice the 3 axes: the anatomic axis of the femoral shaft, which runs slightly oblique, the mechanical axis, passing from the hip to the center of the knee, and the vertical axis. See how the femur tilts inward by about 6 to 9 degrees. That's why the anatomical and mechanical axes don't perfectly overlap. This angulation is nature's way of ensuring efficient weight transfer through the knee joint, preventing us from wasting energy while standing or walking. In the clinic, understanding these axes is essential for interpreting x-rays, planning osteotomies, and even in total knee replacement surgery, where restoring proper alignment is key to joint function and prosthesis survival. Now, let's drop our gaze to the lower image of the distal femur. Here we see the patellar surface, also known as the trochlear groove. This groove is where the patella glides up and down during knee flexion and extension. The groove itself is slightly deeper on the lateral side, which helps prevent the patella from slipping outward, a common problem in young athletes, especially females, leading to patellar instability or dislocation. Moving laterally, focus on the lateral epicondyle. This is a palpable landmark, sitting just under the skin on the outer side of the knee. Attached here is the lateral collateral ligament, LCL, a cord-like structure that resists varus forces. That is, forces trying to push your knee outward. Just beneath the epicondyle, there's a shallow groove where the popliteus tendon passes. Think of the popliteus as the key to the knee, unlocking it during the transition from full extension into flexion. A bit further posteriorly and superiorly, we find the origin of the lateral head of the gastrocnemius, one of the calf muscles. That's why in certain knee injuries, swelling can extend into the calf due to these close anatomical connections. On the medial side, the medial epicondyle is broader and serves as the attachment for the medial collateral ligament, MCL. Unlike the LCL, the MCL is a broad, flat band, blending with the joint capsule and medial meniscus. That's why MCL injuries often involve associated meniscal tears. Just superior and posterior to the medial epicondyle, we find the adductor tubercle, the anchoring point for the adductor magnus tendon. If you palpate your inner knee while contracting your thigh, you may feel this region tighten. And just as on the lateral side, the medial head of the gastrocnemius arises from the posterior superior aspect of the medial condyle. Now, between these two condyles lies the intercondylar notch. This is no empty space. It is the home of the cruciate ligaments. The anterior cruciate ligament and posterior cruciate ligament anchor here, crossing each other like the legs of an X to control forward and backward translation of the tibia under the femur. Damage here, such as an ACL tear, is one of the most dreaded sports injuries, often requiring surgical reconstruction. Finally, the trochlear groove you see anteriorly is not just smooth bone. It is covered with thick articular cartilage, among the toughest in the body. This adaptation is crucial because the patella slides over it thousands of times per day, bearing high compressive loads. So what should you take away from these images? The distal femur is not simply two rounded ends. It is a landscape of ridges, grooves, and prominences, each serving as a docking station for ligaments, tendons, and muscles. Every little bump and hollow you see in the image corresponds to a functional and often clinically significant structure. To keep you engaged, I encourage you now, place your hand on the outer side of your knee and find the lateral epicondyle. That little bump you feel, that's the site of the LCL, the popliteus tendon, and even part of your gastrocnemius. You're palpating the same bony landmarks surgeons use when reconstructing ligaments.
Now, let's rotate our mental image of the femur and examine it from below, as shown in Figure 1.2. Here, we are looking at the inferior view of the distal femur, the surface that directly articulates with the tibia and patella. What immediately stands out are the two condyles, the lateral and the medial. Notice how they are separated by the deep intercondylar notch. This notch is an extremely important region because it houses the attachment sites of the cruciate ligaments. On the lateral wall of the notch, you'll find the attachment for the anterior cruciate ligament, or ACL. Think of it as anchoring forward stability. On the medial wall of the notch, specifically on the anterior and superior surface of the medial femoral condyle, lies the attachment site for the posterior cruciate ligament, or PCL. Together, the ACL and PCL form a crisscross stabilizing system that prevents the tibia from sliding too far forward or backward under the femur. Now shift your focus slightly anteriorly. The condyles join to form the patellar surface, also called the trochlear groove. This groove is divided into a lateral facet and a medial facet. Notice how the lateral facet is steeper, more vertical, and has a prominent edge, while the medial facet is relatively flatter. This asymmetry is not accidental. The steeper lateral wall helps to keep the patella centered during motion, resisting lateral displacement. When this groove is shallow or flattened, something you may see in certain patients, it predisposes them to patellar dislocations, particularly to the lateral side. This is a common issue in young athletes and often presents with repeated knee swelling and episodes of the patella giving way. Now look carefully at the lateral epicondyle again. Just above and posterior to it attaches the lateral collateral ligament, or LCL, as we saw earlier. Immediately below is the popliteus groove, where the tendon of the popliteus muscle passes before inserting onto the tibia. This small but mighty muscle is critical for initiating knee flexion from the locked position. And also remember, the lateral head of gastrocnemius originates here, linking this region functionally to the calf. Now, On the medial side, the medial epicondyle provides attachment to the medial collateral ligament, or MCL. Superior and posterior to it lies the adductor tubercle, where the powerful adductor magnus inserts. And like the lateral condyle, the medial head of the gastrocnemius arises from the posterior part of the medial condyle, further emphasizing how the femur serves as a hub for muscle origins. Now, a clinical pearl for you. When examining MRI scans, radiologists often scrutinize the intercondylar notch. Narrowing of this notch has been linked to an increased risk of ACL tears, especially in athletes. This highlights how even small variations in anatomy can predispose someone to injury. To tie it all together, from this inferior perspective, the distal femur reveals its role as both an articulating surface via the condyles and trochlear groove, and as an anchor point for some of the most important stabilizing structures of the knee, the cruciate ligaments, collateral ligaments, and major muscles. Now, with the femur fully appreciated, it's time to look at its partner, the proximal end of the tibia. This is where the femoral condyles meet their matching tibial plateaus and where the menisci step in to enhance congruity. Now let's take a careful look at figure 1.3, where we see the lateral view of the right distal femur. This perspective is especially valuable because it shows us exactly where key soft tissue structures attach to the lateral femoral condyle. Focus first on the bony landmark marked with an asterisk, the lateral epicondyle. This is our reference point. Around it, you can see three important footprints for ligament and muscle attachments. At the superior-posterior aspect, we have the origin of the lateral head of the gastrocnemius, labeled GNMLH. Remember, this muscle contributes to powerful plantar flexion of the foot, but at the knee joint, it also plays a role in flexion. Clinically, in posterior knee swelling or hematoma, you'll often see this muscle involved since it sits so close to the capsule. Just posterior and slightly inferior to the epicondyle is the groove where the popliteus tendon inserts. The popliteus is a small but strategically important muscle. It's sometimes called the key to the knee because it helps unlock the fully extended knee by laterally rotating the femur on the tibia. This insertion explains why popliteus injuries or inflammation can cause deep posterolateral knee pain. Anchored directly to the lateral epicondyle itself is the lateral collateral ligament, LCL. Unlike the medial collateral ligament, which is broad and blends with the capsule, the LCL is a distinct cord-like structure. It resists varus forces, that is, forces that would push the knee outward. That's why athletes who suffer a blow to the inner side of the knee, forcing it into varus, often tear this ligament. The second image, figure 1.3b, beautifully extends these structures in color, making their paths easier to follow. The gastrocnemius tendon runs downward to the calf, the popliteus tendon dives inferomedially, and the LCL courses vertically to attach to the head of the fibula. Together, these structures form what we might call the posterolateral corner of the knee, a region that is crucial for stability. In fact, injury to this corner, involving the LCL, popliteus, and associated capsule, leads to severe instability and is notoriously difficult to manage surgically. Now, let's put this in context. If you palpate the lateral aspect of your knee just above the joint line, you're essentially feeling the region of the lateral epicondyle. Surgeons use this landmark during knee ligament reconstructions to correctly place grafts, especially for LCL and posterolateral corner repairs. So, to summarize this view, the lateral femoral condyle is not just a smooth joint surface, it is a crowded real estate of attachments, each with a vital role in movement and stability. Now let's turn our attention to the medial view of the distal femur, as beautifully demonstrated in figure 1.4. Compared to the lateral side, this region is even richer in attachments, and it is especially relevant clinically because medial injuries of the knee are more common than lateral ones. The first landmark we must orient ourselves with is the medial epicondyle, marked here with an asterisk. Surrounding it, several powerful stabilizers of the knee attach. At the very top and slightly posterior, we find the adductor tubercle. This is where the adductor magnus tendon inserts. It is a palpable landmark just above the medial epicondyle, and surgeons often use it as a guide when reconstructing medial ligaments. Just anterior to the epicondyle, notice the medial patellofemoral ligament, or MPFL. This small but vital ligament runs from the medial femoral condyle to the medial border of the patella. Its job is to resist lateral displacement of the patella. In fact, when patients suffer from recurrent patellar dislocations, the MPFL is usually torn, and modern surgical treatments often focus on reconstructing this exact ligament. The superficial medial collateral ligament, or sMCL, is perhaps the star of this region. It is a broad, flat ligament extending from the medial epicondyle down to the tibia. Unlike the cord-like LCL, the MCL merges with the joint capsule and even has connections to the medial meniscus. This explains why valgus injuries, such as a football tackle hitting the lateral side of the knee, often produce combined MCL and medial meniscus damage. Just posterior to the MCL, we see the posterior oblique ligament, or POL. This is a thickening of the posterior capsule that provides stability, particularly in extension. It works hand in hand with the MCL to resist valgus and rotational stresses. Finally, at the posterior superior part of the medial condyle, we have the origin of the medial head of the gastrocnemius, or GNMMH. Just like on the lateral side, this origin connects the femur to the calf, reinforcing the close relationship between knee and ankle movements. When you look at the second image, figure 1.4b, you can see these structures in color, making their trajectories crystal clear. Together, the MPFL, sMCL, and POL form what is called the medial stabilizing complex. This system is essential for preventing valgus collapse and excessive external rotation of the tibia. Now, let's think clinically. When a patient presents after a valgus injury, the so-called unhappy triad, the medial collateral ligament, medial meniscus, and ACL are often torn together. Why? Because of their anatomical connections. The MCL is directly tethered to the medial meniscus, and valgus force stretches both simultaneously. To bring this home, I encourage you to palpate the inside of your knee. Just above the joint line, slightly posterior, you may feel the adductor tubercle, and just below it lies the thick band of the MCL, which you can sometimes appreciate as a firm structure in slender individuals. So, if we compare the two sides, the lateral femoral condyle is dominated by the LCL, popliteus, and gastrocnemius lateral head, forming the posterior lateral corner. The medial femoral condyle, on the other hand, carries the MCL, POL, MPFL, and adductor magnus tendon, forming the medial stabilizing complex. Together, they balance the knee against stresses coming from both sides. With this medial and lateral anatomy of the femur clarified, we're ready to move directly into the proximal tibia, where the femoral condyles articulate with the tibial plateaus and the menisci complete the joint surfaces.
Now, let us swing the femur around to its posterior aspect, as shown in figure 1.5, and focus on the intercondylar notch. This view is crucial because it exposes the hidden heart of the knee's stability system, the cruciate ligaments, and their bundles. Look closely at the notch. You can see black arrows in the image marking its borders. Running along this surface are ridges: the lateral intercondylar ridge, the bifurcate ridge, and the medial intercondylar ridge. These serve as bony landmarks that separate the attachment sites of the cruciate ligaments and their different bundles. The anterior cruciate ligament, ACL, which you all know as the most commonly injured ligament in sports, attaches to the lateral wall of the notch. More specifically, it divides into two functional bundles: the anterior medial bundle, which is tight in flexion, the posterior lateral bundle, which is tight in extension. This dual bundle arrangement ensures that the ACL provides continuous restraint against anterior tibial translation throughout the knee's range of motion. That's why when one bundle is torn but the other remains, patients may still feel some stability, though never complete. Now look at the posterior cruciate ligament, which anchors to the medial wall of the notch. Like the ACL, it also has two bundles: the anterior lateral bundle, stronger and tighter in flexion, and the posterior medial bundle, tighter in extension. The PCL is about twice as strong as the ACL, and it prevents the tibia from sliding backward under the femur. Clinically, a torn PCL can be identified with the posterior drawer test, where the tibia sags backward like a sliding drawer. Now, do you notice those smaller labels, AMFL and PMFL? These are the meniscofemoral ligaments, tiny but important fibers that connect the posterior horn of the lateral meniscus to the femur. They course near the PCL and are sometimes mistaken for part of it during arthroscopy. They play a role in stabilizing the meniscus during movement. So, in this posterior view, the intercondylar notch is not an empty space. It is a carefully organized docking station where the ACL and PCL attach with their functional bundles, flanked by the meniscofemoral ligaments. Any surgeon performing cruciate ligament reconstruction must know these footprints precisely to restore natural knee biomechanics. Let me give you a clinical pearl. The narrowness of the intercondylar notch has been shown to predispose athletes to ACL tears because a tighter notch can pinch the ligament during extension. That's why radiologists sometimes measure notch width in high-risk patients. To help you visualize, imagine running your finger down the back of your own knee. Deep inside, tucked between the femoral condyles, are these crisscrossing cords that determine whether you can cut, pivot, and sprint without your knee collapsing. With this, we've completed our detailed exploration of the distal femur, the condyles, epicondyles, ligament attachments, and cruciate ligament footprints. Next, we'll shift our attention fully onto the proximal tibia, where the femoral condyles meet their tibial partners, and where the menisci play their crucial role in stabilizing and deepening the joint.
Now, let's shift our view downward to the superior surface of the proximal tibia, beautifully illustrated in Figure 1.6. This is the tibial plateau, the foundation upon which the femoral condyles rest, cushioned and stabilized by the menisci. Take a moment to appreciate its broad, irregular surface. On either side, we see the medial tibial condyle and the lateral tibial condyle, separated by the central intercondylar area. And within this intercondylar region lie the medial and lateral intercondylar tubercles, also known collectively as the intercondylar eminence. This eminence is more than just a ridge of bone. It is the critical anchoring point for the cruciate ligaments and the roots of the menisci. Now, let's map it step by step. The anterior intercondylar area. At the front, you will find the attachment sites for the anterior cruciate ligament and the anterior roots of both menisci. This explains why, in an ACL tear, the anterior horns of the menisci may also be stressed or damaged. The posterior intercondylar area, at the back, the posterior cruciate ligament attaches, along with the posterior roots of the menisci. Notice how the posterior horn of the medial meniscus is particularly tethered here, explaining why injuries to the PCL often coexist with medial meniscal tears. Now, glance laterally. On the outer side of the lateral condyle, you will find a very prominent bump, Gerdy's tubercle. This is the insertion site of the iliotibial tract, the thickened lateral portion of the fascia lata. Clinically, this tubercle is palpable, and tenderness here may point to iliotibial band syndrome, a common overuse injury in runners. Now, just inferior and posterior to the lateral condyle, there's the fibular articular facet. Here, the tibia articulates with the head of the fibula, forming the proximal tibiofibular joint. This joint is often forgotten, but it plays a role in dissipating forces during ankle movement and can be a hidden source of lateral knee pain. Now, look at the posterior surface of the medial condyle. Here lies a vertical groove, the insertion site of the semimembranosus tendon. This is not a single attachment, but a fan-like insertion. The upper vertical part of the groove anchors the main tendon. The lower transverse part accepts an anterior slip of the tendon. And just medial to this, you'll find the attachment of the posterior oblique ligament, which blends with the semimembranosus expansions. This integration makes the semimembranosus not just a mover of the knee, but also an active stabilizer on the medial side. Finally, note the tibial tuberosity at the anterior aspect. This roughened triangular prominence is where the patellar ligament inserts. Palpate your own knee just below the patella, you will feel this very structure. In adolescence, inflammation of this site can cause Osgood-Schlatter disease, a painful but self-limiting condition. So, when viewed from above, the proximal tibia is a carefully organized platform. The menisci cover the joint surfaces, the cruciate ligaments anchor in the intercondylar areas, the iliotibial band and semimembranosus secure the periphery, and the patellar ligament pulls from the front. Clinically, any disruption to these anchor points, whether it's a meniscal root tear, an avulsion of the tibial spine, the intercondylar eminence, or an inflamed tibial tuberosity, will destabilize the knee significantly. Now, let us shift our dissection perspective to the medial side of the knee at 90 degrees of flexion, as shown in figure 1.14. This view begins to integrate the soft tissues, muscles, tendons, vessels, and nerves that form the living architecture around the knee. First, let's orient ourselves. At the front, you see the patella with the patellar tendon, or ligament, extending downward to insert on the tibial tuberosity. Just medial to this lies the medial patellar retinaculum, a band of connective tissue formed by extensions of the vastus medialis. This retinaculum is clinically important. It stabilizes the patella medially and resists lateral dislocation. When it tears, patients may present with recurrent patellar instability. Look further inferior and you can trace the infrapatellar branches, small cutaneous nerves that run superficially across this region. They can sometimes be a source of numbness or irritation following knee surgeries, especially arthroscopy or total knee replacement. Now, following the natural contour of the medial side, notice the sartorius muscle sweeping obliquely across the knee. Just beneath it, two important tendons converge, the gracilis and the semitendinosus. Along with the sartorius, these three tendons insert together into the medial tibia, forming the well-known structure called the pes anserinus, literally the goose's foot, named for its webbed arrangement. Clinically, the pes anserinus is a hotspot. Athletes and runners often develop pes anserine bursitis, characterized by pain and swelling just below the medial joint line. When palpating a patient, tenderness in this region helps you differentiate it from intra-articular pathologies. Running between these tendons, you see the great saphenous vein coursing superiorly to eventually drain into the femoral vein at the saphenofemoral junction. Alongside it travels the saphenous nerve, the terminal sensory branch of the femoral nerve. This nerve supplies sensation to the medial side of the leg and ankle. Surgeons must take care to protect it during procedures such as vein harvesting for bypass surgery or hamstring tendon grafting for ACL reconstruction. Injury to the saphenous nerve can result in troublesome numbness or neuropathic pain along the medial shin. Behind the sartorius, we also see the robust semitendinosus and gracilis tendons inserting together, while the semimembranosus tendon lies deeper and posterior to this group, contributing to the stability of the medial knee. So what do we take from this view? The medial knee is not just a simple surface, it is a crossroads of structures. Dynamic stabilizers like the sartorius, gracilis, and semitendinosus, the pes anserinus. Static stabilizers like the medial patellar retinaculum, vessels and nerves such as the great saphenous vein and saphenous nerve, which are clinically significant in both surgery and physical examination.
Now we are looking at the posteromedial view of the right knee in extension, as shown in figure 1.15. This view is extremely valuable because it gives us a different perspective on the same structures we saw previously in flexion. With the knee extended, their spatial relationships become clearer, especially the way tendons, nerves, and vessels organize themselves along the medial border of the joint. At the front, you can still see the patella, with the infrapatellar branches extending across the skin and subcutaneous tissue. These little nerves are branches of the saphenous nerve, and they provide sensation to the anterior and medial knee. As I mentioned before, they are often at risk during surgical incisions around the knee, sometimes leading to numbness or even painful neuromas. Just medial to the patella lies the broad muscle belly of the vastus medialis, with its fibers running obliquely, the so-called vastus medialis obliquus, VMO. Clinically, this is an important stabilizer of the patella, working with the medial retinaculum to resist lateral pull. Weakness of the VMO is often implicated in patellofemoral pain syndrome. Now, trace your eye further posteriorly. You'll see the long, strap-like sartorius muscle coursing down obliquely, overlaying the more vertical tendons of the gracilis and the semitendinosus. Together, these three muscles converge to form the pes anserine insertion on the medial tibia. Notice how their tendons are layered, sartorius most superficial, gracilis in the middle, and semitendinosus deepest. This arrangement not only provides strength, but also allows gliding and flexibility during knee movement. Running between and beneath these tendons are two key structures: the great saphenous vein, blue in the colored image, and the saphenous nerve, yellow in the figure. Both travel together down the medial aspect of the leg. This anatomical companionship is highly relevant clinically. The great saphenous vein is the longest vein in the body and is often harvested for coronary artery bypass grafts. Surgeons must carefully avoid injuring the saphenous nerve during this procedure as the nerve runs very close. The saphenous nerve is purely sensory, and injury to it produces numbness or tingling along the medial shin and ankle. Now, the area marked with an asterisk in this figure corresponds to the pes anserine region. This is a frequent site of bursitis, inflammation of the pes anserinus bursa, especially in middle-aged women and athletes. Clinically, patients present with pain and tenderness about 4 to 5 centimeters below the medial joint line, often confused with meniscal or MCL injury. Here in figure 1.16, we are once again on the medial side of the knee, but this time the specimen is positioned at 90 degrees of flexion. This flexed position allows the soft tissues to spread slightly, making the neurovascular relationships easier to appreciate. At the top of the field, you'll see the long, strap-like sartorius muscle crossing obliquely.
Beneath it run the tendons of the gracilis and semitendinosus, which we've already identified as part of the pes anserinus. Their arrangement remains the same: sartorius superficial, gracilis deeper, and semitendinosus deepest. Now, what makes this figure particularly interesting is the exposure of the saphenous nerve and its close companions. The saphenous nerve here is shown together with the saphenous branch of the descending genicular artery, a neurovascular bundle that travels through the adductor canal and emerges on the medial side of the knee. From the nerve, a major branch extends forward, the infrapatellar branch. This little nerve passes anteriorly across the tibial tuberosity, providing sensation to the skin over the anterior knee. Running alongside, as always, is the great saphenous vein. Notice how intimately the vein and nerve travel together down the medial leg. This is clinically significant. When surgeons harvest the vein for bypass grafting, there is a real risk of injuring the saphenous nerve. The result? Persistent numbness or tingling on the medial side of the leg. The colored view, figure 1.16b, really brings these relationships to life. The nerve branches fan out like a yellow net across the knee, while the great saphenous vein is marked in blue. The artery traveling with the nerve provides small cutaneous branches and is part of the rich anastomosis around the knee, ensuring collateral circulation even when major vessels are compressed in flexion. Now, think clinically again. When a patient complains of numbness over the anterior medial aspect of the knee after surgery, especially arthroscopy, it is usually because these infrapatellar branches of the saphenous nerve were damaged by the skin incision. This is a common, though often underestimated, complication.
Now, we have exposed one of the most clinically relevant stabilizers of the knee, the medial collateral ligament, MCL, highlighted here in figure 1.18. Notice first that the pes anserinus tendons have been removed in this view, allowing us to see the ligaments directly. The asterisk marks the medial epicondyle, our bony landmark. From this point radiate several key structures. The superficial medial collateral ligament, sMCL, is the broad, smooth, vertical band running down from just posterior and proximal to the medial epicondyle toward the medial tibia. Unlike the cord-like lateral collateral ligament, the sMCL is flat and sheet-like, extending beneath the sartorius, gracilis, and semitendinosus tendons. Its tibial attachment is extensive, about 6 to 7 centimeters distally on the medial tibia, just anterior to the medial head of gastrocnemius. This wide footprint makes it the primary stabilizer against valgus forces, meaning it prevents the knee from collapsing inward. Importantly, the sMCL functions across all flexion angles, from full extension to deep flexion. Deep to it, though not yet visible here, lies the deep medial collateral ligament, dMCL, which forms the third anatomical layer. This deeper portion blends with the joint capsule and has intimate attachments to the medial meniscus. That is why injuries to the MCL are often associated with medial meniscal tears. When one is stretched, the other suffers. Now, look anteriorly. The medial patellofemoral ligament, MPFL, extends from the medial epicondyle and adductor tubercularia to the superomedial edge of the patella. It blends with the fibers of the vastus medialis obliquus, VMO, creating a strong tether. This ligament is the primary restraint to lateral patellar dislocation, especially in the first 20 to 30 degrees of flexion. Clinically, when a patient has a traumatic patellar dislocation, the MPFL is almost always torn, and surgical reconstruction often targets the structure. Posterior to the MCL, notice the posterior oblique ligament, POL, running obliquely backward from the medial epicondyle region toward the posterior capsule. The POL is not an isolated ligament, but more a capsular thickening, reinforced by the semimembranosus tendon. It stabilizes the knee against valgus stress, but especially against rotational and posteromedial instability. Together, the sMCL, The dMCL, MPFL, and POL form what we call the medial stabilizing complex of the knee. These structures complement each other. The sMCL resists valgus forces, the dMCL and POL resist rotation, and the MPFL protects the patella from drifting laterally. Now, think clinically. The MCL is the most frequently injured ligament in the knee, particularly from a valgus stress, such as a football tackle from the lateral side. Depending on severity, injuries are graded. Grade 1, microscopic tears, pain but stable. Grade 2, partial tear, some laxity. Grade 3, complete rupture, marked instability. Isolated MCL injuries often heal well with conservative treatment due to its rich blood supply, but combined injuries, especially with the ACL or meniscus, usually require surgical management. Finally, let's anchor this to palpation. Place your hand on the inside of your knee, just behind the medial epicondyle. Run your fingers downward. There, you are tracing the course of the superficial MCL. Beneath it lies the anserine bursa, a common site of bursitis that mimics MCL pain. So, in this medial view, you can appreciate how anatomy explains function and how structure predicts injury patterns.
Now we reach an important turning point in our layered dissection, the deep medial collateral ligament, or dMCL, and the corresponding stabilizers on the lateral side, as shown in figure 1.19. Medial side, A, B. Look at the left-hand images first. We already know the superficial MCL, the broad vertical band extending from the medial epicondyle to the tibia. Beneath it lies the deep MCL, a much shorter but equally important stabilizer. The dMCL attaches from the femur to the medial meniscus and then down to the tibia. It is essentially the capsular thickening of the joint, blending intimately with the medial meniscus via the meniscotibial ligament, or MTL, and the meniscofemoral ligament, or MFL. This tight connection explains why valgus injuries often damage both the MCL and the medial meniscus. They are structurally bound together. Think of the sMCL and dMCL as a double layer of defense. The sMCL resists gross valgus forces across all angles of flexion. The dMCL functions as a secondary stabilizer, particularly preventing excessive rotation and transmitting forces directly to the meniscus. Clinically, when the dMCL is injured, meniscal tears are almost inevitable, and that's why surgeons often explore the medial meniscus during MCL repair procedures. Lateral side, CD. Now turn your eyes to the right-hand images. Here we see the lateral epicondyle marked with several important ligamentous structures fanning out. The lateral collateral ligament, a cord-like band extending to the fibular head. Unlike the broad MCL, the LCL is slender and distinct, leaving a space between itself and the capsule. This lack of attachment to the lateral meniscus means lateral meniscus injuries are less common in isolated LCL tears. Just posterior to it runs the popliteofibular ligament, or PFL, a key stabilizer of the posterolateral corner, reinforcing the popliteus tendon. Anteriorly, you see the anterolateral ligament, or ALL, a structure that has gained attention in recent years. It extends from the lateral epicondyle to the anterolateral tibia, closely related to the lateral meniscus. Its function is to resist internal tibial rotation, particularly in flexion, explaining its role in the pivot shift phenomenon seen in ACL-deficient knees. And don't forget the popliteus muscle tendon complex, weaving obliquely through this region. It helps unlock the knee and provides dynamic posterolateral stability. So, Compare the two sides. Medial knee, we have the sMCL plus dMCL plus meniscal connections, and this creates a strong, broad, but tightly linked to the meniscus. On the lateral side, we have the LCL plus the ALL plus the PFL plus the popliteus, and this creates a cord-like, more discrete, but less meniscus involvement, but critical for resisting varus and rotation.
Now, we turn to the lateral view of the right knee in extension, shown in figure 1.22. This perspective allows us to see how the lateral thigh and leg structures blend into the knee joint capsule and stabilizers. Let's orient ourselves first. At the top of the figure, you can see the iliotibial tract, or IT band, a thickened lateral portion of the fascia lata. It runs vertically down the lateral thigh and inserts into Gerdy's tubercle on the anterolateral tibia. This insertion is clinically significant. Pain and tenderness at this site are hallmarks of iliotibial band syndrome, a common overuse injury in runners and cyclists. Posterior to the IT band, the tendon of the biceps femoris is clearly visible. It inserts onto the head of the fibula, a palpable bony landmark. This muscle not only flexes the knee, but also contributes to lateral stability by pulling the fibular head posteriorly. Now, notice the vastus lateralis, part of the quadriceps group, descending along the anterolateral thigh. Its fibers contribute to the iliopatellar band, which blends into the lateral patellar retinaculum, or LPR. These connective tissue extensions tether the patella laterally, balancing the pull of the vastus medialis obliquus on the medial side. When this balance is disturbed, say a weak vastus medialis obliquus, the patella tends to drift laterally, predisposing to patellar maltracking and dislocations. Inferiorly, you can appreciate how the fascia transitions. The fascia lata of the thigh continues as the fascia cruris of the leg. Muscles of the anterior compartment, like the tibialis anterior and extensor digitorum longus, are enveloped in this fascia and contribute indirectly to the stability of the knee. Posterior-laterally, we also see the fibularis longus muscle, emphasizing how the knee integrates with both the thigh and leg compartments.
Here in figure 1.23, we are observing the lateral view of the right knee at 90 degrees of flexion. This position gives us a more dynamic look at how the fascia, tendons, retinacula, and nerves interact across the lateral side. At the front, you can identify the patellar tendon, extending from the patella down to the tibial tuberosity. Just lateral to it, we see fibers of the lateral patellar retinaculum, LPR, which provide lateral tethering for the patella. Some of these fibers extend more deeply to form the lateral patellofemoral ligament, running from the lateral epicondyle to the patella, while others run downward toward the tibia, forming the lateral patellotibial ligament. As the text reminds us, these lateral fibers are weaker than their medial counterparts, which explains why lateral patellar dislocation is far more common than medial. Above this region, the thick band of the iliotibial tract, ITB, runs vertically, inserting firmly into Gerdy's tubercle on the tibia. This tract is an extension of the fascia lata, and clinically, it is the site of iliotibial band friction syndrome, a frequent problem in long-distance runners. Posteriorly, you can see the tendon of the biceps femoris muscle, the lateral hamstring. Recall that this muscle has two heads. The long head of the biceps femoris arises from the ischial tuberosity and is innervated by the tibial nerve. The short head of the biceps femoris originates from the lateral lip of the linea aspera of the femur and is innervated by the common fibular nerve. At the level of the knee, the tendon of the biceps femoris splits into two parts, inserting anterior and posterior to the head of the fibula.
Between the tendon and the lateral collateral ligament, LCL, lies a small bursa called the biceps femoris bursa, which may become inflamed and painful. Now, let's shift our attention to the nerves. Running close to the fibular head, you can see the common fibular nerve, also called common perineal nerve. This is an extremely important structure. It wraps around the fibular neck, where it is most vulnerable to compression or trauma. Injury here produces the classic foot drop because the patient loses dorsiflexion. From the common fibular nerve, we see its two major branches: the superficial fibular nerve, superficial perineal nerve, which supplies the fibularis longus and fibularis brevis muscles and provides cutaneous innervation to most of the dorsum of the foot, and the deep fibular nerve, deep perineal nerve, which innervates the anterior compartment muscles like tibialis anterior and extensor digitorum longus, and supplies sensation between the first and second toes. In addition, we see the lateral sural cutaneous nerve, which contributes to sensation over the upper lateral leg.
Here in figure 1.24, we are looking again at the lateral view of the right knee in extension. 3 different images are shown: one native, one color highlighted, and one focused on the branching of the nerves near the fibular head. Panel A, General Landmarks. The first image shows us the essential framework. At the top, you see the lateral epicondyle of the femur, marked with an asterisk. From here, the lateral collateral ligament, or LCL, runs downward as a distinct cord-like structure, inserting onto the head of the fibula. As we emphasized earlier, this ligament is separate from the joint capsule and the lateral meniscus, which makes it very different from the medial side. Just anterior, the iliotibial tract has been pulled downward so that we can appreciate the deeper layers. It would normally cover this whole region, inserting into Gerdy's tubercle on the tibia. Posteriorly, you can see the tendon of the biceps femoris muscle inserting onto the fibular head. This tendon forms a key part of the posterolateral corner, working with the lateral collateral ligament to stabilize the joint. Running diagonally across the field is the common fibular nerve, also called the common peroneal nerve, coursing around the fibular neck. This is one of the most vulnerable nerves in the lower limb, as it lies very superficially at this point. Around the fibular head, we also see muscular boundaries: the lateral head of the gastrocnemius muscle, the soleus muscle, and tendinous fibers from the extensor digitorum longus and fibularis longus muscles. Panel B, Color Dissection. In the second image, the same relationships are emphasized in color. The lateral collateral ligament is shown as a distinct band extending from the lateral epicondyle to the fibular head. The biceps femoris tendon is highlighted as it inserts posteriorly. The common fibular nerve is clearly visible running across, reminding us again of its surgical and clinical importance. The iliotibial tract and its relationship to Gerdy's tubercle are clarified. This color overlay helps us visualize the layering: superficial fascia and iliotibial tract first, then ligament and tendon, with the nerve running obliquely. Panel C, Nerve Branching. The third image zooms in to show the division of the common fibular nerve. At the level of the fibular neck, the nerve splits into the deep fibular nerve, or deep peroneal nerve, which runs anteriorly to supply the anterior compartment muscles: tibialis anterior, extensor hallucis longus, extensor digitorum longus, and provides sensation between the first and second toes. The superficial fibular nerve, or superficial peroneal nerve, which supplies the lateral compartment muscles, fibularis longus and fibularis brevis, and gives cutaneous innervation to most of the dorsum of the foot. You can also see a small branch to tibialis anterior, highlighting how the nerve distributes motor supply early on in this passage. Note how close these structures lie to the fibular head. Any trauma, surgical error, or prolonged compression in this area can damage the common fibular nerve and its branches, leading to foot drop and loss of sensation over the dorsum of the foot.
Now we move on to figure 1.27, which gives us a lateral view of the right knee at 45 degrees of flexion. In this dissection, both the iliotibial tract and the tendon of the biceps femoris have been removed so that we can clearly appreciate the key ligamentous structures of the lateral side. Main landmarks. At the top, you can see the lateral epicondyle of the femur, marked with an asterisk. Just below that landmark, two very important ligaments arise and run in slightly different directions. The lateral collateral ligament, LCL, also called the fibular collateral ligament, this ligament originates just proximal and posterior to the lateral epicondyle. It runs obliquely downward in a cord-like fashion, finally inserting on the lateral surface of the head of the fibula. Unlike the broad and flat medial collateral ligament, the lateral collateral ligament is round in cross-section, resembling a tendon. It is extracapsular, meaning it does not blend with the joint capsule. In fact, there is a clear separation between the lateral collateral ligament and the lateral meniscus. This anatomical detail explains why lateral meniscus tears are less frequently associated with isolated lateral collateral ligament injuries. The anterolateral ligament, ALL, just anterior to the lateral collateral ligament, you can see this more recently described structure. The anterolateral ligament extends from the lateral epicondyle down toward the anterolateral aspect of the tibia near Gerdy's tubercle and the lateral tibial condyle. Its function is to provide rotational stability, particularly resisting internal rotation of the tibia. Clinically, the anterolateral ligament has been linked to the pivot shift phenomenon seen in anterior cruciate ligament, ACL, deficient knees. Many researchers believe that injury to both the anterior cruciate ligament and the anterolateral ligament explains the severe rotational instability seen in some patients.